All right, folks, so you've learned a lot about neurotransmitters in the last few minutes, and I want to bring this into a practical application, and that is the use of amphetamines or amphetamine-like molecules like methylphenidate to treat attention issues. So in this, we're mostly going to be talking about dopamine and norepinephrine. Now, it's just an interesting little footnote in that what we now call attention deficit hyperactivity disorder was once called MBD or minimal brain dysfunction. And as you can see, some of the same concerns that might might be a concern for parents or teachers today are kind of similar to what we were seeing in the early days of treatment with methylphenidate or Ritalin, but definitely a more sort of pejorative way of looking at this. So I want to talk a little bit about how ADHD evolves over the lifespan and talk about some of the likely neurocircuits that are involved with ADHD and how we can manipulate those with different drugs to get a clinical outcome. So, in order to diagnose ADHD, you need to have several things. There needs to be a persistent pattern that happens over different domains. So, it's really important that this isn't seen as something that can just happen at school or just happen at home. If somebody has ADHD, they have it in all aspects of their lives. Now, to be clear, it may show up more predominantly in a place that requires more cognitive effort, such as school or work. But generally, if you really drill down with people about diagnosis, you'll see things in their non-work life, such as forgetting to return library books or not paying bills on time, leaving clutter around the house, projects half finished, things such as that, in addition to the characteristic problems with work or school. And there's a sort of persistent pattern of both inattention and also hyperactivity and impulsivity. Now, if you've read the Gami text, you'll see that he and I would probably disagree somewhat on this. He feels that the what is known as hyperactivity is really an anxiety response to not being able to focus. And I think it's an interesting point, and I don't necessarily have anything to refute that. But I have definitely seen a kind of hyperactivity in children, of course, but also in adults sometimes. Although typically you get less of the hyperactivity in adults, you tend to get more of the inattention, and the hyperactivity often will kind of fade away as people age, but not always. You definitely see people, adults with ADHD, who can be quite fidgety, and that ideally you're getting confirmation from other informants and such as school or parents, and that you've ruled out other conditions which might impair cognition, such as anxiety or depression. Obviously, if somebody is in the midst of a major bipolar episode or psychosis episode, their attention is going to be significantly impaired, and you don't want to mistake that for ADHD. So this is really what makes the ADHD diagnosis. And demographically, it's around 5% of children and about 2.5% of adults who have ADHD. Kind of be hard pressed to know that from some of the media that's out there right now. And there seems to be a lot of sort of market pressure to diagnose ADHD in adults, and some of that is coming from telehealth companies that have fairly low standards for diagnosing and treating ADHD, who are somewhat controversial. And it'll be interesting to see how that plays out over time. But really, if we think about very young children, say preschool age children, if you were to walk into a preschool, you'd see kids that look like they have ADHD, but you wouldn't call it that because at that age, we expect children to have a fairly short attention span and a compulsion of moving around. And so this sort of early years, we really can't be diagnosing people before the age of about 6 or 7 because it's not clear, how that's going to change. It's thought that part of the reason why this happens is that the brain myelinates or wraps those insulation cells around axons slowly over time, and it starts at the posterior of the brain and moves its way forward. And so these circuits in the prefrontal cortex, which are really most essential um, for discernment and focus and distractibility, are sort of the last to get myelinated. And so that may be why ADHD like symptoms may persist in some people over time is that process just takes longer. And then sometimes over the course of middle school and high school, you see those symptoms improve. And then usually the patients that we get as adults who are complaining of ADHD symptoms are usually telling us that they started to really notice problems, or teachers started to say, I know Johnny is smart, but he doesn't seem to be working up into his full potential sometime around the beginning of middle school or high school, or definitely early college at the latest. So most people mature out of these symptoms, and we should, by definition, find ADHD symptoms in adults that began in childhood. So what this is to say is that you can't have adult onset ADHD. Now, you may not have been diagnosed, but if you dig back through a history of somebody who has ADHD as an adult, they should have had ADHD symptoms as a child. These kind of TikTok-like videos sort of drive me a little bit batty. Let me just play a little bit of some. Or this one.
The very first question that I ask any patient who presents in my office saying that they have ADHD is, did you used to sprain your ankles a lot as a kid? The next question is, are you covered with mystery bruises, or did you used to be all the time? I don't remember banging myself into anything, and yet here's a bruise, here's a bruise, here's a bruise. The third thing that I will ask them is about their digestive systems. Do they tend to have bad gut health? Do they tend to get upset stomach really easily, or have a lot of food sensitivities, or just gassy bloating? And then the last thing that I'll ask is, do you have a history of skin conditions, whether it's seborrheic dermatitis or dandruff, or rosacea, or eczema, or psoriasis, or cystic acne in your history, especially at puberty, worse than average acne? And the reason I ask all of these questions is because all four of those things, from sprained ankles and loose ligaments, to mystery bruises, to digestive system orders and skin conditions, are all highly associated with ADHD neurotypes. So why, and what can we do about it?
Okay, so these kind of quick diagnosis videos are really challenging to us as clinicians, because what they really are promoting is this sort of idea that let's skip on to the next one here. Is this idea that a single symptom is pathognomonic. And what we often will see is patients will come into our office, and what they're essentially saying is, I have poor attention. Okay. That's like me taking you outside at night, giving you a paper towel tube and pointing it at one star and saying, what star? What constellation is that star part of? If you were only seeing that one star, you really would not have any idea, right? So if I said, well, here's poor attention, and then we start to zoom back and we start to look at what other stars, what other constellations, what are the symptoms are constellated around this star, and we started seeing something like this. We'd see, okay, low mood, anhedonia, slow motoric activity, sleep disturbance. Well, wait a second. This doesn't look like ADHD at all. This looks like major depression. So we have to be careful not to jump to conclusions with one symptom. And I know these sort of videos are really enticing because I think they give people a sense of understanding why they are the way they are. And it may indeed be ADHD, but it also could be a lot of other things. So we want to remain sort of diagnostically agnostic until we have a greater picture of things. It's useful to use standardized diagnostic screens such as the ASRS. Of course, people can find these online if they want to overstate their symptoms, sort of to know where the thresholds are. I don't think that's probably as widespread as some clinicians might think it is, but I do think it's important to think about how do we ask these questions in maybe a somewhat standardized way. In really marginal cases, some people will send for a neuropsych evaluation, but a lot of neuropsychologists don't really like getting involved in ADHD, so you might have trouble, let alone finding a neuropsychologist, but finding one who likes to do diagnosis of ADHD. So very often this is going to be a clinical diagnosis that you're going to make, just like you might diagnose generalized anxiety disorder or major depression. Now, it's important to note that that there are, of course, these other things that should probably be treated first. So if somebody comes in with an active substance use disorder complaining of inattention or distractibility, that substance use disorder really needs to be treated first. And this is a clinical challenge when we run into, say, people that are using a lot of cannabis and then present with ADHD symptoms, because we know that cannabis can certainly mimic a lot of ADHD types of symptoms. So I'm particularly uncomfortable prescribing somebody a stimulant, for example, who's using a lot of cannabis. So that would need to be treated first. And then if there's an underlying mood disorder or an anxiety disorder, I'd want to see that treated as well, because those are two things that can definitely impair cognition. Now, a lot of adults will get those things treated, but then their ADHD sort of goes undiscovered. And a lot of kids will present with ADHD symptoms that are actually part of a more complicated picture of anxiety and mood disorders. And they don't get those mood and anxiety disorders treated, but they get put on a stimulant medication. So their ADHD gets better, but perhaps their mood and anxiety doesn't really. Or maybe their anxiety is even made worse by a stimulant medication, which is possible. And then there is this higher occurrence of nicotine use among people with ADHD, and that sometimes doesn't get treated at all. So the area of the brain that we're most interested in when we treat ADHD with stimulants like amphetamines and methylphenidate is the prefrontal cortex. And this is where the wiring for attention and uh, behavioral and emotional control are largely housed. So on obviously the sort of phenotype of ADHD shows up as poor impulse control, difficulty with sustaining attention, getting easily distracted. These are kids that are constantly noticing what's going on around them in a classroom. If you have a history of ADHD, you probably know that sitting in the back of a classroom, for example, is not really great for your attention because you get distracted by all the things that are in the foreground. And so, many people with ADHD will have accommodations to allow them to sit in a less distracting part of the classroom, such as the front row. And then people get frustrated, and this frustration may lead to this sort of hyperactivity, anxiety kind of presentation, because these are kids that really struggle with focusing, even though they might be quite bright. That they struggle with focusing for an enduring period of time, which is what we ask kids to do in school, and of course, we often ask people to do that at work too. So as I mentioned earlier, when talking about dopamine and norepinephrine, there is this sort of sweet spot. And when we're starting to manipulate these neurotransmitters with stimulants, we'll see this. So we'll see often when we add a stimulant and the dose is too low, that what'll happen is there's really not a lot happening. It's sort of the person is underdosed, right? When we hit that sweet spot, we really get to this place where there's adequate norepinephrine and dopamine activity going on that's really kind of tuned up these circuits to allow greater focus. But if we overshoot the mark and we get too much dopamine and norepinephrine going on, or that would be an example if we use too high of a dose of a stimulant, we'll actually kind of create ADHD-like symptoms again, but it'll have more of that kind of hyperkinetic quality to it. So when we think about when these drugs get misused, for example, so methamphetamine use is often associated with this kind of hypermotoric state where people are kind of fidgety and moving around, and their movement is somewhat purposeless. They're kind of going from one task to another and not focusing. So that's really when we've sort of overstimulated these circuits. So we want this kind of sweet spot, and I will sometimes, if I feel confident that the patient is able to do this, I will give people a reasonable range of a stimulant medication. So I might give a drug like Adderall, 10 milligrams and up to 40 milligrams, and I will let them do 10. I'll say, go ahead and do 10 milligrams each morning for, say, the first 3 days. See if you notice anything. If you don't notice anything, go ahead and go up to 20 milligrams. Now, at 20 milligrams, you'll probably start noticing something, and you might, and start thinking like, the catchphrase I look for is this how other people's brains work? Because that's a sign that we're probably getting closer to some kind of useful improvement in focus and attention. And then you'll probably get interested, like, what would 30 milligrams be like? So you go to 30 milligrams. May turn out 30 milligrams is even better. than 20 milligrams. Or it may turn out that 30 milligrams is like, whoa, this is too much. I feel like I'm distracted and I'm kind of feel anxious. So you go back to 20 milligrams and that's your dose, or maybe somewhere between the two. It might be 25 milligrams. But that's often how I'll start with sort of dose finding, because different people are going to need different doses of these medications. And for some people, 20 milligrams hardly touches them, and they might need 30 or 40 or even 60 milligrams a day. Other people, take the idea of taking 60 milligrams of Adderall would make them crawl out of their skin. So part of what you have to do as a clinician is figure out what is the correct dose for each patient. So norepinephrine and dopamine have this kind of close relationship in the prefrontal cortex. So the norepinephrine transporter will actually pick up norepinephrine and dopamine, and there's a lot more dopamine transporters. Or sorry, there's a lot more dopamine compared to the amount of transporters in the prefrontal cortex. So dopamine will get pulled up along with norepinephrine by these norepinephrine transporters. And so some norepinephrine reuptake inhibitors, such as atomoxetine, that's Strattera, do not have any impact on dopamine transporters. And so they just increase norepinephrine. And by inhibiting that reuptake transporter, secondarily, they reduce the uptake of dopamine, but they're not causing dopamine to be released in the nucleus accumbens, which is important because the nucleus accumbens is where we register reward. So somebody does, say, snorts a bunch of methamphetamine, they're going to get dopamine release in the nucleus accumbens, which is going to get that sort of reward signal that we're familiar with dopamine signaling in drugs of abuse. So just a quick reminder about how dopamine is released. It's released from those vesicles at the presynaptic neuron. We've got that dopamine transporter here represented by this blue box. So that's the dopamine reuptake pump or dopamine transporter. And it's pulling that dopamine out of the receptor. So the drugs that we're using that are going to affect this, and we'll talk about how they do that in a moment, are the stimulants. And by that, I mean amphetamines. So that's like Adderall, dextroamphetamine. So Adderall is a racemic mixture of dextroamphetamine and levoamphetamine. We can also just use dextroamphetamine alone. So that's Dexedrine. Methylphenidate are your Ritalin type drugs. And then we have our non-amphetamine drugs such as atomoxetine, the alpha-2 noradrenergic agonists, guanfacine and clonidine, and then some of these what are traditionally thought of as antidepressant medications that happen to work on norepinephrine and dopamine, such as bupropion and some of the tricyclic antidepressants. Okay, I think I covered that. So sometimes people get a little overwhelmed when they see the list of ADHD meds because it looks like there are dozens and dozens of medications for ADHD. Here's your cheat code. Most of them, if they are stimulants, are methylphenidate or amphetamine in some form or another. Now, they vary in their pharmacokinetics, meaning that some may last longer than others. Some might actually take some time before they begin to release, and there are different strategies for why that might be useful. But most of them are some variation of amphetamine or methylphenidate. And there are non-stimulant medications as well, but don't get overwhelmed. So when I say overwhelmed, this is what I'm talking about. So these are all methylphenidates. So I've highlighted with the red box here your classic Ritalin that's been around for 70 years now. So that's your immediate release methylphenidate. You see the half-life there is somewhere around 3 to 4 hours. And then a common long-acting methylphenidate would be Concerta, which has been around for a good 25 years now. And its duration of action is somewhere around 10 to 12 hours. So this is intended to be a once a day, taken in the morning kind of drug. And then you see variations on the theme here. So Focalin is the right enantiomer of methylphenidate, so dexmethylphenidate. So different variations on a theme here. There's a new drug out on the market called Astaris, which is dextroamphetamine plus dextroamphetamine, which is a prodrug of dextroamphetamine. So the idea is the dextroamphetamine begins to work right away, and the serdextroamphetamine is converted to dextroamphetamine over time. and gives you action later in the day. So different ways of approaching this, but all variations on that theme. And then turning to amphetamines, we have sort of classics would be dexedrine or dextroamphetamine with half-life. Um, so that 1 to 2 hours, so about 3 to 5. There should be a dash between there. I apologize. So about 3 to 5 hours of direct duration of activity. So this is something you're going to have to dose 2, maybe 3 times a day, and then Adderall, which is going to be lasting for most of the day, really intended to be for most people a QAM drug. Some people will need Adderall extended release. So extended release is meant to be a QAM drug. The immediate release is usually a BID drug. I have a few patients who need Adderall extended release, a second dose, but usually taken no later than sort of midday, because the main side effect that we're going to deal with all of these stimulant medications is insomnia and appetite suppression. Those are the biggest problems that you deal with when you're looking at stimulant medications. So sometimes people need to eat before they take the medications so as to prevent weight loss. But those are mostly what you're dealing with is managing side effects by looking at the pharmacokinetic profiles of the drug. Some outliers here, Vyvanse is lisdexamfetamine. So that is lysine attached to a dextroamphetamine molecule. Interesting. We'll talk about that in a second. And then you have these non-amphetamine things such as clonidine, guanfacine, which is marketed as 10X, atomoxetine, which is Strattera, and then bupropion, which is the same Wellbutrin that we use for depression, is an off-label use of that for treating ADHD. So we've talked about enantiomers several times, but it's useful to remember what that means here. So that D is short for dextro, which means right in Latin. Levo or L is left, sometimes abbreviated S for sinstra. So that means the left side of the molecule. So let's take a look at this. So racemic methylphenidate would be your Concerta, Ritalin, all those things, and then you have the dextromethylphenidate, which would be Focalin. That's the right side of the enantiomer. Methylphenidate has a dual mechanism of action, which means that it inhibits both the norepinephrine transporter and the dopamine transporter or reuptake pumps. It does not cause a direct release of either dopamine or norepinephrine, but it increases the amount in the synapse by preventing their reuptake at the synapse there by inhibiting those transporters. And when we look at methylphenidate preparations, we've got several different ones to choose from, which vary in how long they last. So your classic is that methylene, also known as Ritalin. The nice thing about this is it's short acting, sort of 3 to 5 hours, commonly used in children because you can dose this at the beginning of the school day and maybe get through the school day. You might need to redose at lunchtime with the school nurse, something like that, but less likely to cause insomnia at the end of the day. So it gives you some more flexibility, but some people don't like that sort of up and down that you get with the shorter acting drugs. And there has historically been this idea that shorter acting stimulants might be more reinforcing and therefore more prone to being abused. Your medium acting methylphenidates would be things like the ER drugs. So Ritalin ER, they're sort of the middle duration. So these are sort of 5 to 8 hours, also marketed sort of more for children and people just about to go to work who really only need the help with their attention at work. So these are going to last for about 5 to 8 hours. Still have some potential for causing insomnia, especially if you forget to take it later in the day. But then I would say most people probably go, sometimes as first line, I certainly do often, to the long-acting drugs. So important to counsel patients that you have to take this at the beginning of the day. If you realize you got to 4 o'clock and you forgot to take it that morning, don't take it. Because remember, this drug, you actually want it to leave your body every day. So unlike, say, an SSRI, where we need chronic exposure to the drug for it to have its therapeutic effects, with the stimulants, if they're still around when somebody tries to go to sleep, they're going to have a hard time sleeping. So this is not a drug that we need to see, quote, build up in the body. And of course, you know from what we've talked about neuroplasticity, it's not a question of the drug building up in the body, but it's the downstream cellular effects that it occasions. But with the stimulants, we really want the acute effects and then we want them to stop. We want the drug to leave the body. So this means that, if somebody decides they don't want to take it on weekends, I'm okay with that. Or they don't want to take it during school holidays, I'm okay with that. Because if you don't need the help with cognition and attention, it's probably okay to skip it. So Concerta is kind of the go-to here. Concerta is an interesting drug because it has a little bit of immediate release. About 1/4 of the drug total dose is immediately released, and then the remaining is released over the next 8 to 12 hours or so. But this is definitely a drug that can cause appetite suppression. Sometimes people need to eat before they take it. This is how Concerta works. It's interesting. You should warn patients that they might find what appears to be an undissolved pill in their stool in the toilet. That is actually a plastic capsule. They're called ghost pills or ghost shells. And it's just a plastic capsule that contains the drug. And what you can see here are these very small holes that are, I understand, drilled with lasers into the plastic capsule, which allows fluid from the gut to flow via osmotic pressure into the capsule and then push it out the end, which is very clever. So this is what causes that slow release. And then the empty capsule is released in the stool. And this is what allows the slow release of the drug. But you can see where this might be a problem for, say, somebody who, for whatever reason, has a shorter gut, like who's had a gastric bypass, could be a real problem. You might need to use immediate release drugs for those folks. Let's talk about the amphetamines. So we have that right enantiomer, dextroamphetamine there, kind of a classic. We have the dextroamphetamine plus lysine, which is Vyvanse or lisdexamphetamine. And then we have the racemic mixtures of both amphetamine or dextroamphetamine or levoamphetamine. Adderall is actually 3 parts of dextroamphetamine to 1 part levoamphetamine. So it's primarily dextroamphetamine. Sometimes it's referred to as a mixed amphetamine salts. So if you see that, don't get confused. It just means racemic amphetamine, right and left. Now, amphetamines work similarly to methylphenidate. So they do bind and slow the dopamine transporter, but they also cause this dopamine release. So we've got dopamine being directly pushed out into the synapse from the amphetamine molecule, and they also prevent the reuptake of norepinephrine. So in the way that they're similar to methylphenidate is that they both cause inhibition of the norepinephrine transporter and the dopamine transporter. But where they differ is that amphetamines actually push dopamine out into the synapse. So we've got this kind of 3-part mechanism of action for amphetamines, which is different than methylphenidate. Amphetamine preparations would include things such as Adderall immediate release, dextroamphetamine or dexedrine. Again, similar guidance that you would have with the methylphenidate. Short-acting ones are great for sort of short periods of time, maybe for a young child with a shorter school day, but often will need to be redosed for the full school day, and certainly for people's work. And then the long-acting things would be dexedrine spantules, Adderall XR. Vyvanse is a fairly long-acting drug. And the nice thing about these is that, you're not asking somebody who has attention problems to remember to do something twice in a day. Sort of do it once in the morning, maybe when you're brushing your teeth, and then forget about it. But they do have that risk of causing insomnia and appetite suppression. So there's that lysine molecule that's attached to dextroamphetamine. And what that basically does is it makes it into a prodrug. So until you swallow Vyvanse and that lysine molecule is cleaved off, the dextroamphetamine is inactive. And what this is intended to prevent is route diversion. So if somebody wants to take a Vyvanse and crush it up and try and snort it, it won't do anything because that lysine is bound to the dextroamphetamine, making it inactive. And it's only the gut that can cleave off that lysine. So similar as if you were to grind up Vyvanse and inject it, it would not have that. It would not have any effect because the dextroamphetamine would be rendered inactive as an inactive prodrug unless it's cleaved by gut enzymes and becomes free dextroamphetamine. It has a long duration of action too, which is nice. Other things that we can use instead of amphetamine. So bupropion essentially is kind of a weak amphetamine. It's primarily it's more like a weak methylphenidate, really, is probably a better way of putting it. It works as a norepinephrine and dopamine transport reuptake inhibitor. Atomoxetine has kind of a similar effect. In fact, atomoxetine was originally, this is Strattera, was originally developed as a competitor to bupropion as an antidepressant, but in clinical trials it didn't do very well. And so Eli Lilly went back to the drawing board, and reportedly that's where the concept of adult ADHD originated from, was that they sort of promoted this idea that ADHD doesn't necessarily end in childhood, but that adults can continue to have it, and that created a significant market for atomoxetine. There's a new kid on the block called Viloxazine. This is, I believe, called Quillabri. This is a norepinephrine, dopamine, and serotonin reuptake inhibitor, which is interesting. But its dopamine and norepinephrine effects are the target for ADHD, and it's approved currently in children. Clonidine is a noradrenergic alpha 2 A, B, and C agonist, which causes norepinephrine release in the prefrontal cortex, which is where we want it for attention. And then guanfacine has a similar kind of effect. So we get that increased norepinephrine activity in the prefrontal cortex to help with attention. So this is a reasonable way of thinking about ADHD. So if somebody has, for some reason, that they can't have a stimulant, let's say they have recent cardiovascular events such as an MI or an arrhythmia, I would definitely get sign off from cardiology before I begin that. Or if they have a recent stimulant use disorder, you want to be cautious. I mean, there are some um, more, I would say, clinicians that are fairly bold, but I think this is not an unreasonable way of thinking about it, that are starting to talk about using stimulants in people with stimulant use disorder in much the same way we use methadone in people with opiate use disorder. The idea of having a safer supply and one that is taken orally reduces harm compared to potentially contaminated drug supplies and those that are taken through routes other than oral, which subject people to risks such as skin infections and injection site problems. But if for whatever reason you don't feel comfortable using a stimulant, then you can think about things like atomoxetine or bupropion. Also, guanfacine is another option, or clonidine. Those are also useful medications for people with PTSD. So that might be something to think about if somebody has a comorbidity of PTSD and ADHD. But generally, if you're okay with using a stimulant, you're going to start. Now, some people, you'll develop your own personal preference around this. When I first started, I would use short-acting stimulants like Ritalin or Adderall immediate release to kind of dose find, and then I would try and convert people to the extended release. And some people actually preferred the immediate release. There's definitely a feeling, either the feeling of the drug kicking in is definitely more significant. I think your time to peak is shorter, and um, your Cmax is probably similar, but your Tmax is shorter with the immediate releases. And so people will really feel like that kind of feeling that their ability to focus is really kind of kicked on. And so I often now will just start with an extended release. So I'll start with that 10 milligram dose of something like Adderall XR, and then we'll talk about adjusting the dose accordingly until we find that sweet spot, which is really improving their cognition and their attention, but not so far as to make them fidgety or anxious. And then if you have comorbidities, it gets a little trickier. So if somebody has ADHD with psychosis or fragile bipolar disorder where they're prone to mania, you got to be really careful. So I would probably only proceed with that if they have a long-acting injectable antipsychotic on board to create kind of a hedge against potentially triggering psychosis and mania. And you're going to want to be really careful with proceeding with that. So again, some other sort of algorithms that you can think about here, um, pretty much repeating what I've just said. Things that you want to be careful with, you don't want to combine an MAO with a stimulant, MAOI rather, because remembering that norepinephrine and dopamine are broken down by MAOI or MAO. So an MAOI, an inhibitor, is going to inhibit that enzyme, which is likely to cause hypertensive crises. So you don't want to combine those two things. You will get flagged by your pharmacy for potential serotonin syndrome when you combine a stimulant with an SSRI. I think it's more of a theoretical risk than a common one. So I don't lose a lot of sleep about that. And then since many of our amphetamines are processed through 2D6, a 2D6 inhibitor can raise the levels of amphetamines when it's introduced to somebody who's already taking an amphetamine. So you'd want to be careful with something like bupropion if you're adding that to an existing amphetamine regimen. Now, all stimulant medications, methylphenidate and amphetamines, are likely to cause some of these sympathetic kind of nervous system side effects. So, dry mouth, increased heart rate, um, feeling kind of jittery, constipation, quite common. Insomnia, obviously, being an obvious one, especially if people take it too late. There is some evidence that stimulants can suppress growth in children. I think we'll talk more about that in later units where we talk about ADHD specifically. And there, you can have induction of mania in people that are prone to it. So if I have a patient who has had a history of mania, I would only treat ADHD if they had a steady regimen of a prophylactic mood stabilizer on board, such as lithium. But I would also be really cautious with them and tell them to monitor their sleep, because loss of sleep is often a trigger for people to get into a manic episode. So you want to make sure that if people are taking a stimulant, it's not disrupting their sleep. And then there's this tricky issue of diversion and misuse. So, misuse and diversion do occur. College campuses are sort of known for, there can be, people will share stimulants, and I would encourage you to have a conversation with all of your patients about how these medications are for them and for them only, and they're not to be shared. I will post a couple of different versions of stimulant contracts. You can use your clinical discretion as to how you want to deploy these. At one point in my career, I had everyone sign them, and that seemed a little bit unnecessary. And so now I sort of reserve them for people that I'm concerned might misuse or divert the stimulant. And I do this not to be punitive, but to be clear. And so I really want my patients to understand, like, what is an on-time refill? A lot of times we're a little bit cagey as clinicians about what we consider an on-time refill for a controlled substance. Well, I spell it out. I say 5 days before it should run out. Obviously, you're going to have to think about your pharmacy and how that works. Like, my pharmacy at the VA can be a little bit slow, especially if it's being mailed. So I'm fine with 10 days before it should run out in that situation. But you want to give this some thought, and then you want to get in the habit of using the prescription drug monitoring program databases. So California, we call ours Cures, but as a licensed clinician, you have access to this, and you should get in the habit of checking to see if the prescriptions that they have for controlled substances are ones that you are familiar with, or are they getting them from multiple prescribers. And I encourage you to check out this website called StreetRx. This is run by the Rocky Mountain Poison Control Center, which I think is a fascinating sort of use of internet crowdsourcing. So you can you can put in data on this if you have acquired a diverted pharmaceutical drug. You can submit that information into there, or you can look up what other people paid based on a certain geography, and you can see this is what people are paying per pill. So you can kind of get a sense for what your medications that you're prescribing might be worth in other contexts. So, in summary, treating ADHD, I would say it's one of the most satisfying things that I get to do as a clinician because it really works. A lot of our medications are, iffy. They work sometimes, but not all the time. Stimulants in ADHD are pretty darn reliable. They tend to work. This is probably why patients like them, which, I think some clinicians will mistake that as drug-seeking behavior. I see it as more like relief-seeking behavior, which makes sense. I think most of us, when we're in distress and having symptoms, we want relief, and stimulants generally provide that. And so the main thing we have to just manage is the side effects and to make sure that we're using them safe and that they're not being diverted. We do want to keep an eye on cardiovascular risks. If you have somebody who has cardiovascular questions, I would definitely get collaboration with either primary care or if they have a cardiologist to think about that because we can see mild increases in blood pressure and such. But in general, these can typically be done fairly safely. And we just want to be clear and transparent about our expectations with these medications as we prescribe them. So I hope this is interesting. I'm sure we'll have more conversation in the chat, and I look forward to that. Thank you for your attention. Bye.